We like to think of precision medicine as adapting early, that is before standard of practice, new testing modalities which have the ability to detect the risk of a disease prior to the onset of the pathology. That's an important advancement for medicine because it gives the physicians in the community the opportunity to intervene on the risk and prevent the pathology. Medicine is practiced today by a patient coming into the hospital or coming into the office with a chief complaint of an illness. And so the medical profession is reactive to the disease. That is, you're intervening on already progressing disease. That's not an efficient way to practice medicine. What you would hope to be doing is identifying what that patient has as a major risk to health, and then to intervene by therapeutics for that function. Now, the advancements that have taken place in genetics enable you to probe the whole genome, and with biomarkers, proteomics, and also metabolomics. So we have really powerful new tools that have not been put into standard of practice. So the physician community is going to need to think ahead of the disease. How can I find the risk and intervene on the risk to give my patient a longer and a more fulfilling lifespan? That is the objective, and that's what we're trying to do. Precision medicine has had its greatest uptake, I think, in my opinion, has had its greatest uptake in the area of children's inborn errors of metabolism. Those are genetic disorders, in which many of the disorders you have to have high technology to be able to identify the disease and treat the child. And then in the adult arena, I think the uptake has been highest in the area of oncology, cancer, using whole genome sequencing of one's somatic DNA, that is not with cancer, and by comparing that to the DNA changes that take place with mutations in cancer, one can identify frequently the pathway you need to follow for therapeutics. As an example, if you had mutations in non-small cell carcinoma, and you found mutations in epidermal growth factor, there are drugs that are specifically targeted to that particular mutation, and one can use so-called targeted therapy for that patient. In other patients, you will have a plethora of mutations, so-called high mutational load. It is not possible at this time to give the patient a cocktail of 4 or 5 drugs that target individual genes in that circumstance. But the development of immune modulation has been a godsend to this type of patient, because as you mutate the genes, you create many abnormal proteins, which the patient's immune system is recognizing as a foreign cell. So the immune modulation drugs help enhance the rejection capacity of your own immune system to attack and kill the cancer cells. So those are 2 examples, one targeted and one a totally new class of therapeutics and immune modulation. Those are the best examples that I can think of, the pediatric undiagnosed disease cases and the application of the science of precision medicine in the cancer area. Now, it's extending into other disease areas, but those are the leaders, in my opinion. Cardiovascular disease follows that pretty quickly. There's a quote from Churchill that I love, that I think is relevant to this question. And his comment was, Americans try many things before they do the right thing. And I feel like the stage that we're at right now in precision medicine is we're trying many things. The availability of the platforms that are available to us, whole genome sequencing, metabolomics, proteomics, RNA expression, these tools are being applied as we evaluate a single patient. Now, already there have been remarkable discoveries that have been made out of this strategy. Did everything that we do work out? No, did not. So what one has to do is to look for those signals that actually advance medicine, validate them, and then move them into standard of practice. So we're at the early stages of testing the tools to find out the utility of application to the vast population for precision medicine.